Good afternoon. My name is Dr. Elizabeth Leibach, and I'm very pleased to be with you today to speak with you about uses for clinical laboratory informatics and decision support, the primary mechanism for adding value in healthcare delivery from the laboratory standpoint today. Excuse me for the delay. I'm looking at all my controls. This is a very exciting endeavor for me for this webinar, and I wanted to tell you too, before we get too much farther into the presentation, that I am in Augusta, Georgia, and the weather is beautiful. However, we have been having some thunder showers in the afternoon, so hopefully those won't interfere with our broadcast today. I also wanted to mention before I go, I've made a couple of notes here that we will be having questions and answers for the last 15 minutes or so of our session today. And so if you would make notes of those and submit them, and then we will discuss them at the end of the presentation. And also, I had several things that I was supposed to remember to do. One of them was to talk to you about the question and answer session. But the other one was to add a slide on how you can obtain continuing education credit for this symposium, this webinar. If you are so interested, the session has been approved by the AACC for their CMEs, and there is a website that you should go to for application for the credit, and let me read it to you because I forgot to put it in my last slide. So that website is www.bioconferencelive, all one word, .com/CME-CE. So again, the website is www.bioconferencelive.com/CME/CE. So thank you very much. And I also wanted to tell you that today we're going to talk a lot about evidence-based practice in laboratory medicine, or laboratory medicine evidence-based practice, and specifically the theory surrounding that, and sort of describing for you a whole research agenda for the laboratory medicine community related to clinical diagnostics, and to convince you that in fact informatics is a pivotal piece to our analytics capability going forward in this endeavor. So toward that end, then, our objectives for today's session are to define evidence-based practice in clinical laboratory science, to summarize the evidence-based practice connections among critical thinking, quality improvement, patient safety, and expert practice, and also to describe the relationship of evidence-based practice to practice skills, specifically informatics, required in today's healthcare delivery system. The evolution of evidence-based practice really parallels the evolution of quality and quality systems development. So beginning the discussion of evidence-based practice and informatics support of evidence-based practice should begin with the discussion of quality. So I have on this slide a picture for you of a laboratory in the beginning of the quality control days in laboratory medicine. And I want you to know that this is not a picture from some dusty archive somewhere. It is actually a picture of the first lab that I worked in as a medical technologist. So it really is not that long ago, but as as we can see, as we will see as we go through the slide, there have been a lot of changes, and I think clearly you'll see the evolution of our quality practices. Back in the beginning of our quality methods in the laboratory, circa 1960, laboratory quality was centered around a menu of about 60 tests that were all manual in their methodology. The quality was specifically defined as quality control. Patient safety related to direct patient care only, and payment was fee for service, and capital expenditures were passed through to healthcare financing at the federal level. Non-laboratory physicians made diagnostic decisions, and what I mean by that is that literally if a physician wanted a test, then the order was made and the test was done. There were no questions about relevancy or efficiency, medical effectiveness, and even not even efficacy that often in terms of sensitivity and specificity. But I'll remind you that we only had a menu of 60 tests. Quality now in laboratory medicine is quite different. We have a test menu of approximately 10,000 tests, and with our molecular test menu growing, we add tests virtually every day. Quality includes quality control measures, but also incorporates concepts of quality improvement and total systems quality, of which our quality improvement and quality control efforts are a part, and we have a few slides that talk more about that. Capitation is very common in terms of reimbursement, and today non-laboratorians make diagnostic decisions just like they did in the old days, but the non-laboratorians are not necessarily they are not necessarily physicians, but often they are what we commonly call mid-level practitioners. So the bottom line is our interpretation of quality for these other healthcare practitioners is even more critical than it ever has been. So in summary, the slide that you see now is sort of summarizing the interconnections of quality control, quality assurance, and quality improvement. Quality control is control on basic analytic processes, and the CLIA recommended an individual quality control program is based on level of risk acceptable for each of these processes. I'm going to persuade you later, hopefully at the end of this session you will be persuaded that in fact for our risk assessment in CLIA recommended IQCP programs, we should actually include, we should consider health outcomes as well, and we'll talk about evidence-based practice methods as being a way to incorporate these health outcomes into our processes of quality. Quality assurance, then, are performance measures that come from quality control and are identified and monitored, tracked over time. Quality improvement being analytic QC process data from all QA studies that are then evaluated as a group and improved as a group. This slide is my way of kind of showing how each of our analytic units then in the laboratory fits into the broader total quality management plan of a system. In a total quality management or continuing process improvement program, processes are cross-cutting throughout the enterprise. Improvements rely on evaluation of each of the individual units that contribute measures to them, and analytic feeders are organized at the system level. System-level performance measures are complex and meaningful in all analytic units. That's a requirement. Then for quality improvement at the individual level, our processes that are concomitant with the total quality management programs are plan, do, check, act, lean, which includes just-in-time measures of inventory. Most of these are related to cost efficiency endeavors in terms of quality, and Six Sigma as well. Improvements in these areas impact system-level performance measures, and it's measures chosen from these studies that then will feed into the larger total quality management measures at the systems level. Sort of a game changer in our measurements of quality in the laboratory occurred at the turn of the century. In 1999, a groundbreaking, record-breaking report from the Institute of Medicine was announced, and this report documented a large number of patient deaths, and that resulted as a function of errors, medical errors, so that a new set of patient safety aims were recommended and have pretty much driven all efforts in quality improvement in healthcare since that time. Those aims are safety, efficiency, timeliness, equity, effectiveness, and patient-centered care. All of these aims collectively are moving our healthcare delivery system toward one that is value-based and not volume-based as it was in the old days, in the beginning of our quality measurements back in the 60s. So from this point in the presentation, we will talk about basically how to move from this volume-based healthcare delivery system to a value-based healthcare delivery system in specifically terms of laboratory medicine and what that means for our operations and how we actually look at quality. The method I propose to you today, that is the method that will get us there in that transition from volume-based to value-based healthcare delivery for our laboratory community, is an evidence-based approach. This is the core idea of evidence-based approach in medicine in general and laboratory medicine in specific. First, the core idea is that our practices, in fact, should be based on evidence of effectiveness. The problem with this is that practice, as we know it today, is not always supported by evidence from clinical research. Instead, we often practice because we've always done it that way, and because it's efficient for us, not necessarily that health outcomes are improved or even downstream costs for our institution are improved. The solution then is to determine what is in fact effective through evidence-based evaluations of our practice, so that in a nice compact definition, evidence-based laboratory medicine is the conscientious, explicit, and judicious use of the best evidence from clinical laboratory information in making decisions about the care of individual patients. So, Evidence-based practice for medical laboratory practitioners then incorporates skills, and we'll talk a lot more about this, that we've never really developed in our past practice in our iterations of quality that relied on instrument evaluation. Those are statistical evaluations that really are based on instrument performance, which we have down very well in terms of our quality for our instrumentation. But evidence-based practice in the broader sense, particularly related to patient-centered care, depends on looking at quality measures in the analytic phase too. Focus should be on accurate and precise measurements there, and also assessment of medical orders as well as specimen collection, storage, transportation, and accession. Then also on the post-analytic phase, consideration of interpretation, communication, and utility in clinical decision support. All of that is part of evidence-based practice and builds on, of course, the analytic phase. Let's take a common, as an example, let's take a common quality measure for the clinical laboratory, and that is hemolysis rates. Hemolysis can occur if blood samples are improperly collected. This we know. That hemolysis then can result in testing errors and sample rejection, and those actions of testing errors and sample rejection then can cause retesting that results in patient delays in treatment or sometimes inappropriate interventions in their care and treatment. So pre-analytic bias can lead to errors in analytics, which can then lead to patient safety dangers. So this is an example of a measure in the laboratory that is cross-cutting across other areas of our institutions and healthcare facilities, and requires studies that bridge other delivery services within our hospital, and requires the participation and collaboration of other healthcare providers in reducing the rates of hemolysis or improving these measurement parameters. The potential of evidence-based practice is that quality is increased in healthcare. The products are increased in quality, the processes, the performance that maximize value for all consumers the quality of all these areas are increased. The evidence-based practice portends to operationalize quality services delivery in all phases of the diagnostic testing process, so that actually our practice will be data-driven rather than expert-driven, and our results then can be used with confidence in medical decision-making. The availability of defined, consistent clinical research designs and methodology with potential for generalizing and benchmarking will be available so that our quality improvement programs will not just be internally utilized, but we'll be able to share them among the laboratory community so that all practices, best practices, will be standardized within the community. Then our best practices link practitioner clinical research, their competencies, and their education. So from the beginning of the career path for the medical laboratory professional, these best practices and the research that should be conducted in order to define best practices should be taught from the very beginning. And we should also then include other healthcare practitioners on the other end in establishing and implementing these best practices that we have discovered through our clinical research. In fact, evidence-based practice is based on clinical research, and through this clinical research, quality improvement efforts in our total quality improvement programs are in fact linked to clinical research. And I might just add here that because of that and the linkage of our patient data to that, informatics becomes critical in documenting patient consent and IRB approval for these clinical studies. The slide that you have before us, before you now, is actually a method that for evidence-based practice, research, and quality that is called the A6 systematic review method. On the right-hand side of your screen is the method for the six steps of the method that are incorporated in the systematic review process from which best practices are gleaned and reported. On the left-hand side of your screen, though, is a modification of the six-step method that can be followed for implementation of these best practices and for then iterative evaluation of the results of these practices. So quickly, I would like to just identify for you out loud the 6 steps. So the 6 steps are ask, acquire, appraise, analyze, apply, and audit and assess. At the ask step, then, is pivotal and is the first really critical and has to be addressed critically in the beginning of the process, and that is the formation of the clinical question. What is it that, what is the problem in healthcare delivery? What is the problem in delivery of laboratory services that needs to be addressed? So here at this level, then, all sorts of other methods that are commonly used in the laboratory can contribute to the honing of a precise clinical question, like the plan, do, check, act, and root cause analysis steps that we are very familiar with in the laboratory can be used to actually define a clinical question. Then the step that is added in the A6 method that you usually don't find in typical quality improvement studies is a review of the literature. For the systematic review process, that second step requires a huge exhaustive review of literature. For the application step, or the acquire step in the implementation side on the left, the process for doing QI studies, the literature review does not have to be that detailed, but you'd be looking in the literature to identify studies that have been published as being solutions to the problems that you're looking for and that you're looking at in your institution. The next step is to appraise, and that is to synthesize the results of this literature review and create an evidence-based base, and then decide which best practice in the literature is the one that fits your process and in your protocol in your facility the best. Apply is then to implement the intervention in your facility, and to then audit, assess is the last step, and that is to evaluate the results of your study to see where further improvement should be considered. Of course, this is an iterative process and a cycle in its nature, therefore the name, the A6 method or the A6 cycle. I want to depart a little bit from a direct discussion of all the 6 steps of the A6 cycle, although we will talk about those in a few minutes, to say that that important for us in laboratory medicine is an understanding that our work, our clinical research that we're about to discuss in terms of evidence-based practice and clinical outcomes and medical effectiveness of our laboratory testing, relates to the broader literature related to health services delivery. These aspects of health services delivery are education theory, social theory, access theory, organizational systems theory, economic theories, and theories of isomorphic pressures that drive decision making in individual clinical facilities, like mimetic, coercive, and normative forces that we'll define in subsequent slides. All of these, though, come down to the clinical laboratory through the prism, if you would, of quality theory. And that is through knowledge translation and the quality framework that was given us by Donna Bedian, who did so much good work in quality in health services delivery. And then in specific, you can see the next to the last step is the A6 method. So the A6 method I propose to you is actually the methodology to evaluate these different hypotheses or clinical research questions that come up through our work in health services delivery. So evidence-based practice, actually, that whole construct for us has put us into the area of health services delivery research, and we should be examining these clinical questions through that broader literature and reporting our findings in the broader literature. So that being said, I want to say also that evidence-based practice has roots in learning theory, and this is a slide that I've included for you because I think it's just really, it's because it's jam-packed with information. Not only is it kind of fun to look at, but it is very instructional. But I'm not going to go into every aspect of the slide. That can be for homework for you. But suffice it to say that there is critical thinking theory that relates to higher order processes of thinking and skills that we employ in evidence-based practice that then allow us to accumulate the knowledge that we transfer through our evidence-based methods to things like Six Sigma and A6 method and patient-centered care in our health services research and clinical research in the laboratory. Educators are very interested in how to construct learning and transfer situations that would mimic the authentic practice role in evidence-based practice, and all of this relates to research that they are doing in the, if I can go back, in the area of critical thinking and knowledge transfer, and it's really fascinating. So in sort of summary then of all the theory business, down at the bottom of this slide, we see that A6 method is the quality framework linking clinical outcomes in the laboratory to patient safety indicators and informatics analytics. So then on the left-hand side of the bottom, you see our quality control efforts that then feed into the A6 cycle, into the total quality management system in our institutions. Then we see that outside pressures suggest treatment algorithms and patient safety targets. Competitive forces impact how we view our laboratory diagnostic information. Regulation, of course, certainly has an effect on how we view our laboratory data and what we choose to do in terms of our test, offer in terms of our test menu, etc. And then, of course, best practices that we benchmark among ourselves also impact how we do our business as a community in laboratory medicine. Then each individual healthcare practitioner has a base of evidence-based practice, and this translates knowledge to total quality management operations as well, and feeds back to us as to how we should improve the information that we provide to these other practitioners. So it's a very complicated system. All those pieces as well should be actively researched by laboratorians. What are some implementation strategies then for evidence-based practice? Well, first, you need to identify informatics and analysis capabilities. We have a great opportunity today with the electronic health record to actually begin to evaluate health outcomes and health indicators, health measures, patient outcome measures, evaluate and correlate our laboratory information relative to those health outcomes like we've never been able to do before. Going through a patient record, a paper patient record, is prohibitive in terms of acquiring all the measures, the indicators that you would need to have to be able to really measure the medical effectiveness of our laboratory testing. However, with the advent of the electronic health record, this is becoming a possibility. However, currently, we are struggling with standardization of language and nomenclature for these measures. In addition, our laboratory database is not often relational to the point that we can correlate our test values with demographics and diagnostics, or rather diagnosis information of our patient database. So those two databases often don't speak to each other. But going forward in this talk, the assumption will be that those informatics capabilities will be available to you for setting up these clinical investigations that have become a part of laboratory quality. Then we need also to determine opportunities for high impact interventions, and I might say here, because I'm going to talk a little bit more about this too, that our whole basis of quality is evolving from a quality control and quality process monitoring, as we see with our statistical quality control and our Lean Six Sigma studies, to one that is based on risk. What the A6 method allows us to do, and we'll talk more about this in subsequent slides, is to bring in health outcomes into that risk assessment mix. And we'll hopefully, by the end of the talk, convince you that in your quality improvement studies going forward, that they are not complete unless you build in measures of medical effectiveness into those quality improvement studies. We need to identify performance measures, of course, and then search the medical literature for applicable comparative effectiveness and outcome studies, as well as best practices and practice guidelines. Before I leave that slide, I might make a shameless plug for a website that is maintained by the Centers for Disease Control and Prevention that actually catalogs best practices in laboratory medicine. I have a link for it, or information on the URL in the last slide, which is a list of references for you for additional reading. Please, I urge you to go visit the laboratory medicine or best practices website, which is called futurelabmedicine.org. And look at the best practices that have been cataloged so far and read more about the evidence-based lab medicine effort that is underway at CDC. In terms of deciding which quality improvement process is most imperative to address first, in other words, deciding on the clinical question that would is the basis of the answer to the question of the problem that is occurring in your laboratory that you would like to research. A good way to do this would be to employ a variation of the Pareto rule, which is to look at diagnoses in your operation that either have the highest cost or the highest volume, or carry the highest risk in terms of total resources. And then we'll actually go through an exercise with determining this. But once you've decided then which diagnosis you should examine first, then we can start accumulating the information that we need in terms of that second step in the A6 process. We need to look at the informatics that are available and the use of information technology, because undoubtedly this is where the performance measures are going to come from. Search the literature for best practices, and then design a clinical study to address the question. What we have found in searching the literature for best practices is that though a lot of analytics are reported in terms of test efficacy, sensitivity, specificity, and predictive value, there are limited numbers of publications related to medical effectiveness and best practices in terms of test algorithms for addressing specific diagnoses. Then often, even when we find these publications on medical effectiveness, the studies are conducted in such a way that definite conclusions can't be drawn that can be benchmarked to other institutions. So this is kind of typical of quality improvement studies in the past, because the results of those quality improvement studies were never meant to be generalized. They were meant to be utilized to improve processes within a specific institution. So this slide is important. Is a listing of important study components that should be considered carefully when you conduct or when you design a quality improvement study, and then of course later when you implement it. In the design side, define a measurable question first of all, and formulate hypotheses. Carefully define the population you'll be looking at, and carefully describe the setting and describe the study period. All three of these areas, if not carefully controlled or carefully described and carefully understood from the researcher standpoint, can add bias to the results of a study. So certainly in reporting these studies, one should elaborate thoroughly on the population, the setting, and the study period that were incorporated into the study design. The intervention practice should be carefully described, as well as the baseline process to which the comparative or the intervention will be compared. Then, of course, in terms of outcomes, not only should clinical laboratory traditional outcomes be measured, but also health outcomes and patient outcomes should be monitored as well. So identify and define outcomes and measures that relate to health outcomes, and then describe carefully the appropriate analytic methods and expected results. So when we think of informatics, we think of, usually, in my opinion, we think usually of the electronic health record and a sort of a transcription of a paper kind of process. But I maintain for you today that integral in that should be the analytics capability, because that's really what we need in order to be able to perform evidence-based practice in laboratory medicine. So we need to know then a lot of skills related to statistics, and particularly data mining and statistics related to big data, as the term is used today. The slide that you have before you now is a consultation logic model that I propose is a way of determining with data, in a data-driven, evidence-based way, which methods and which problems in the lab you should be addressing. If you actually document the consultations that come into the lab, making sure that you document what medical topic is being discussed and what medical service the consultation is coming from, then an analysis of this would give you an idea of the diagnoses that are priority for you to consider in working up the problems that are presented to the clinical lab. This is a slide that is an example of the analytic frame related to the hemolysis problem of sample rejection due to hemolysis that we discussed before. This was actually a best practice review that was done at the CDC, and the interventions that were looked at are listed in the center of the slide. The recommended, from this review, the recommended practice to best address the rejection of samples due to hemolysis is to actually implement a phlebotomy team. And to not draw through an IV set, but to do a single needle draw, not through an IV set. And that those two practices were the best at preventing sample rejection due to hemolysis. I'm watching my time here and want to spend a little bit of time on the slide that you see before you now, which is a slide that is a composite of the A6 method and 3 different studies that were implemented using the A6 method. So these are QI study examples that link pre-analytic and analytic test phases through the A6 method. The question that was asked, if you'll look at the bottom of the arrow, the 3 questions that were asked in 3 different studies. The first question, well, let me back up a little bit and say that these problems were identified through indicators that are commonly measured in quality control efforts in the laboratory. We found that there were turnaround time issues related to 3 processes, and those processes were sample rejection and mislabeled specimens and blood culture contamination. So studies were then designed to address each one of those issues and why we were seeing increased sample rejection and increased mislabeled specimens and increased blood culture contamination. So current, if you look at number 4, analyze, current practices were evaluated and pre and post designs were implemented so that our quality measures were measured after the interventions were implemented. The interventions were for the specimen rejection that there were no IV draws. So with with implementing a single needle draw situation, we found that, in fact, I'm having a little problem with my computer here. Bear with me. We found that the rate of hemolysis or rejection due to hemolysis went way down. Then with the mislabeled specimens, we found that the best practice was barcoding. That barcoding, in some cases, completely eliminated the mislabeled specimen issue problem. And then with the blood culture contamination, implementation of a phlebotomy team that was well trained in blood culture collections greatly decreased the number of contaminated blood cultures that were found in the laboratory. All right, excuse me a minute again. Let me see, now I'm back. Oh, good, good. This slide I inserted into the slide deck to remind you to keep this process in mind as you are employing informatics analytics in your QI studies and the incorporation of health outcomes into these studies. The HITECH Act ushered in an era of information exchange that has just begun. All of this is being either our EHR products are being standardized through NIST or through the Office of the National Coordinator in terms of the EHR development. So in this process, I urge you to there are options and ways for you to have a voice, and you need to pay attention to what's happening at the national level with the informatics analytics development, and make sure that we have the capability of actually connecting our laboratory data to the EHR data and then to population level data going forward for the ability to really be able to make the most of our clinical informatics. Just winding up then our talk, I wanted to leave you some points to remember. First of all, in terms of mimetic pressures that are kind of forming the laboratory community's progress going forward. We are competing. We are competing on value these days, not on volume, not on our extensive menus, but we're finding that reimbursement favors overutilization, and looking at medical effectiveness is a way to determine what value our clinical laboratory tests really are adding to health services delivery, and in the future this is the way we'll be paid based on this value. So we need to know what value we're bringing to the healthcare system. We need to organize horizontally as a laboratory community, so we need to conduct these studies on quality, and we need to benchmark them and communicate and publish. We also need to encourage knowledge translation through informatics. So we need to develop informatics programs related to the laboratory. We don't need to rely on computer scientists or informaticians to do this. We need to become laboratory informaticians. In terms of cohesive pressure, we know that that reimbursement and regulation is a driver in our community. We need to do root cause analysis and transition planning, and we need to pay attention to what's developing in the regulations. And we need to re-engineer all of our processes related to quality. Our reimbursement, I'll reiterate, is going to be value-based, not fee-for-service going forward. Our body of knowledge is crucial. We need to be communicating that knowledge, and not only to our practitioners, our own practitioners, but to other healthcare practitioners as well. They are looking to us for guidance in their medical decision making, and we need to know what our value is in that arena. Wisdom is key. We need to integrate IT. We need to critically think. We need to pay attention to our knowledge translation, our vision, and succession planning. How can you get involved? As leaders of the laboratory, increase the rigor of your QI projects, create a culture for clinical research, and disseminate findings. In the technical workforce, participate in QI and TQM activities. Use the A6 method for conducting quality improvement studies. As an educator, introduce CT and evidence-based practice methods to your students early on and encourage their projects. And students use the A6 methods in your quality improvement process and learn clinical research methods, methodology and design, and also collaborate. I'll leave you with this one last slide, which is Dilbert. And Dilbert is there talking to Wally. He says, Wally, I've decided, Wally says, Dilbert says, Wally, I've decided to move your project due date up a month. So Dilbert says, well, every time it looks like I'll reach an objective, you move it. What does this prove about my performance? And Dilbert says, it proves I'm better at setting objectives than you are at achieving them. So the bottom line here is, don't get comfortable. Just when you think you have all the answers, all the questions change. Here is a list of additional reading if you'd like to explore the evidence-based practice movement more. And you should have handouts as well that are available to you. I'm going to move now for a few minutes of Q&A, and I'll say too that that if we have questions that can't be covered in our time, that I will be glad to have you email me or email LabRoots, and then they can send the emails to me and I'll answer them via email. And also you can, remember, download your handouts, and I think there might not be so many formatting problems with them too. So there is a question here. Having been a programmer and an HMO working with both health records and data warehousing, where do you include, all right, just a minute, where do you include the necessary step of validating data value mapping, cleanliness, and using different relational database models in the aggregate? I think that this is a very detailed question about really validating the exchange of information between the laboratory database and the health record database. I think that currently the electronic health record is not considered a medical device, but in the laboratory community, our blood bank systems, our transfusion medicine systems are considered medical devices, and with that requirement, or with that categorization, there's a requirement for data validation. And I definitely think that as we go forward in the development of these databases, that these sorts of clinical research projects related to standardization of nomenclature and validation of data data warehousing, all of those things need to be considered clinical research projects and need to be conducted. I think they'll need to be conducted by our laboratory information systems vendors, as well as the electronic health record vendors. And I don't think that a lot of those studies are currently being done. Models for those kinds of efforts, though, exist in the big commercial databases, and even the CMS databases. In terms of defining data elements, there's an iterative process that occurs there, so that perhaps if our vendors were willing, they could actually incorporate a process like occurs in our commercial databases, our commercial insurance databases, to validate and standardize the data elements that will be, of course, the foundation for data warehousing. So now that is a laboratorian sort of view of what needs to be done in an informatics world. An HMO actually is a very good opportunity for standardizing some of these processes and reporting those. It would be a great boon to the laboratory community if, in your position in an HMO as in informatics, if these processes and standardizations and language issues, data element definitions, could be benchmarked and published, I think that would go a long way toward helping us standardize the community and hasten our availability to the informatics that we need to really do appropriate medical effectiveness and evidence-based practice. All right, so I'm looking at my broadcasting time, and I think that's probably as much time as I have, so I'll close now. And thank you very, very much for your attention, and be looking forward to any questions that you have via email. Don't forget, your CEUs are available at www.bioconferencelive.com/CME/CE. Thank you very much. Bye-bye.